In our last video, we talked about suicide rating scales and checklists and alternative ways to other than the free-form risk assessment to try to assess risk. And in this video, we're going to talk about other alternative approaches that really aren't exactly rating scales or checklists, but are more like a new diagnosis or a new syndrome or a new collection of symptoms that go together. And the first one I want to mention is that there is such a thing in the DSM-5. In the back of the DSM-5, there are a group of things called conditions for further study, which means they're not really official diagnoses, but they're listed there so that it will stimulate research. And then the idea being perhaps in the future these will become official diagnoses. And so there is one called suicidal behavior disorder, listed in this appendix to the DSM-5, and it has very simple criteria as I've listed here on the slide. Basically, the person has made a suicide attempt in the last 2 years. The act was not, you see on the slide I wrote NSSI, that's the fairly widely known acronym, non-suicidal self-injury. So non-suicidal self-injury, or NSSI, means self-cutting, self-burning, ways that people try to harm themselves, but it's motivated by a desire to feel better or to break through a negative mood state or to break through a dissociative state. The motivation is to feel better, not to die, even partly to die. So in this DSM-5 suicidal behavior disorder, the suicide attempt was at least partly intended to die. It was not suicidal self-injury. In addition, you can't apply this diagnosis to just suicide ideation or to preparing for suicide. It wasn't carried out when the person was in a delirium or confused, and it was not taken, the suicide attempt was not undertaken as a part of political or religious belief system or with those kind of goals. So it's really simple, and it's really kind of unclear to me what the point of this is, I think, other than, because it's very narrow, it's just one thing, a suicide attempt. And I think the idea, though, would be if this were approved as an official diagnosis, it would get a code number, and then every time it came up, when someone was admitted to a hospital or someone saw a private therapist or a private doctor, this would get coded, this would get sent to insurance companies, and then sometime later people could do large-scale studies correlating and looking at people who met criteria for this and what other diagnoses they met criteria for. Beyond that, it's hard to see how this would be much of an advantage over anything. Now, there are a couple other proposed, these are nowhere near being proposed for the DSM, but these are syndromes that are being currently studied with the idea being hopefully there will be a better way to assess suicide risk than what we've done so far. And one of them is called the acute suicidal affective disturbance, and I've included 1 or 2 articles in Sakai, in the required reading that pertains to this one and the suicide crisis syndrome, which we'll talk about in a minute. So the acute suicidal affective disturbance is a rapid increase in suicide intent, marked social alienation, a perception that it's not going to get better, nothing's going to go away, and then 2 or more symptoms of physiological arousal or hyperarousal. And you can see I've sort of compressed these onto the slide. And this one is being studied to see if it's a better way to do risk assessment. Another one in a similar vein is the suicide crisis syndrome, also an alternative to traditional risk assessment. And the advantage of this one, the authors say, and I think this may be true, there's no questions directly about suicide, so it undercuts someone's tendency perhaps to minimize or lie or evade the answers when you ask them directly. Although, as I've said before, I think for the most part, people, as long as you can present yourself as a non-judgmental, active listener, that you can empathize with their thoughts about suicide as a solution to their problems, then I think people are pretty honest for the most part. But if you recall the intent question and the prediction question are particular ones that I think people are much less likely to be honest about. So there's some advantages to something like this. And the suicide crisis syndrome also includes in the discussion, in the assessment, an implicit acceptance that you understand that suicide can be a solution to problems. That's that empathy with the suicidal wish that we talked about before. So the criteria then for the suicide crisis syndrome, and again this is laid out in one of the articles that I've asked you to read in much more detail, is persistent or recurrent feelings of entrapment. So entrapment is one of the main concepts here, which is a sense of being stuck in an intolerable life situation with an urgency to escape but the inability to do so. The person doesn't need to be thinking about suicide explicitly. And then the criteria are, first, an affective disturbance, that is, emotional pain or negative emotions, mood swings, anxiety, anhedonia. Second, loss of cognitive control. In other words, a person ruminates about their state and can't break out of it. Overwhelming profusion of negative thoughts, things like that. They're stuck in this negative mindset and they can't seem to get out of it. Hyperarousal, again, as we saw with the previous acute suicidal affective disturbance. In this case, they specify agitation or hypervigilance or irritability or insomnia, and then the fourth criterion is social withdrawal. So this one also is being studied to see if this will then produce a better way to do a risk assessment. And then finally, I just want to mention ERPOs, extreme risk protective orders. And this is not an assessment technique, this is an intervention technique that's mostly applied to firearms. And the idea is, and the focus when this is in the news, or when this is talked about in much of the literature, is to prevent danger to others. But it turns out that no surprise that it's also appears to be protecting people from danger to themselves as well. And this is the idea of that when family or friends or police think that someone might be dangerous to self or others, they can go to a judge and request a temporary court order to have those guns removed from the home. And they have to show probable cause. It's a hearing in front of a judge. 16 states have ERPOs in place, including Illinois, where it's called the Firearm Restraining Order. Most of the states that have laws like this, there's no requirement for mental illness, which is one of the main ways that we can distinguish this from involuntary hospitalization. So mental illness is required for involuntary hospitalization. Mental illness is not required to get an extreme risk protective order. Now, one group, and I've included this kind of a handout in Sakai for you to look at in more detail, the Educational Fund to Stop Gun Violence. From their research and their findings, they think that for every 10 to 20 risk warrants that are issued, one life is saved. And you can take a look at the handout and they'll tell you more detail about how they've calculated that. On the other hand, there are other groups that dispute this finding. Obviously, you would think that the NRA and groups like that would be against something like this, and they certainly are. And in Illinois, just to mention this one briefly, where it's called a risk protective order, it works in two ways. You can have a regular risk protective order, or you can have an emergency. Actually, it's called a firearm restraining order, FRO, firearm restraining order. You can have a regular one when a petitioner, who could be, again, intimate partner, it could be family, could be friends, or it could be police, petition the court to have firearms removed from an individual when there is, and the petitioner would argue there is probable cause. The respondent is notified, the person who the guns would be taken away from is notified, and a hearing is held within 30 days. And if the order is granted, then the police are required to remove guns from that person's home for a period of 6 months. There's also an emergency protective order, when the hearing is held the very same day or the next day, and if the order is granted, the firearms are removed as soon as possible, and the order stands for at least 14 days, and then during that time a regular hearing is held. This information is from the Illinois Legal Aid online website. All right, so this is just a brief picture of some of the alternative methods that people are looking at for both assessment and intervention. Now, I guess I want to add that the level of detail I've talked about here, while not great detail, is still not what I'm going to ask you about on the exam or anything like that. I think I might certainly ask you to define what an ERPO is, an extreme risk protective order, or I might ask you simply what is an acute suicidal affective disturbance or a suicide crisis syndrome. Just the very big picture, but I will not ask you any of these criteria, the details, the 14 days versus the 30 days, anything like that kind of detail. All right. So I'll see you later.